Small pupil cataract surgery. Cataract surgery in the eye that does not dilate well. This is a case I found from 2016, almost 10 years ago now. You can see the pupil is quite small. Here we're injecting viscode viscoelastic to fill the anterior chamber. We can see there are posterior synechiae from about 5 o'clock to about 12 o'clock. So covering at least 6 to 7 clock hours. This is a keratome making the main incision. This is from 10 years ago, so the video quality is not quite as good. But I think we can illustrate the main points here. It looks like here I'm enlarging the incision a little bit more than that. It looks like a 2.2 blade. So posterior synechiae, how do we approach this? The first thing I probably will end up doing is going in with a cyclodialysis spatula to free up the posterior synechiae, free up the iris from the underlying lens, from the underlying cataract. You can use actually very many different instruments you can use to do this, but I found the cyclodialysis spatula works really quite well and is quite adequate for this part of the procedure. So we freed up the posterior synechiae. So now we have several options here for how to proceed. You can see the pupil is quite small, maybe about 4 millimeters. Looks like I'm going in here with viscoelastic to see if I can dilate it any more. And so you can do viscodilation or viscomydriasis, see if you can get the pupil any bigger, and that actually enlarges probably enough to do capsulorhexis. Of course, at this point in time, you also have the option of placing a Malugin ring or similar pupillary expansion device or using iris hooks. It's important to use technique that you're comfortable with. It's important before attempting to do these kind of surgeries without a pupillary expansion device that you're comfortable placing iris hooks or rings, so that if you do get into trouble, you can always stop the case and place an iris hook at that point in time. So there's a little bit of a delay here. It looks like I'm contemplating and considering different options. As I said, this case is from 10 years ago, but it looks like I'm ultimately going to go in here with the cystotome and start the capsulorhexis. So this is where before I started creating a flap with one continuous motion, you can see I move to the side and then I make a few extra motions there to lift over the flap. And then I'm going in here with my capsulorhexis forceps. These forceps were actually quite nice. They weren't cross-action forceps, but they did have markings every millimeter or so, so you could tell exactly how big your capsulorhexis was going to be. And you can see here that I'm making the capsulorhexis right at the pupillary edge, and even I'm not too scared to go underneath the pupillary margin. I think you'll find, and there I'm sizing the capsulorhexis there, and it looks like it's about 5 millimeters. I didn't actually catch that. But I found that when you go underneath the iris margin, it's pretty rare that the capsulotomy will run out. I'm doing a hide dissection here. It looks like I am tenting up the capsule. This is before I had observed that you could do this, had the sign called the triangle sign, where you can lift up the capsule and see where the capsule is mechanically separated from the lens, which you really can't do in a small pupil anyway. So at this point in time in my career, I think I was doing hydrodissection and hydrodelineation both. Hydrodissection, of course, is separating the cortex from the nucleus, and then hydrodelineation is separating the epinucleus from the nucleus. So going in here with phaco, this is a Venturi system, which is what I used back then, the Bosch & Lomb Stellaris. And I would go in and I would make just a central core where I could put my phaco probe in, and then I use the same chopper, the Nagahara chopper, to do a horizontal chop maneuver. So let's see how that plays out here in this eye with a small pupil. I'm going underneath there. Of course, you can't see what you're doing here, but the anatomy, that's a nice crack. But you know the anatomy, and if you're staying close to the nucleus, you're going to push the capsulorhexis opening aside, and you're going to go around the equator and chop that nucleus. And we've got a quarter of the nucleus here chopped, and it looks like I'm going to go ahead and take that now. Obviously small pupil, so we want to avoid getting the pupillary margin in the phaco probe. And we're making some progress here. It looks like we got most of that quarter out. rotating the nucleus. And we're probably going to do some more horizontal chop here. But so for these small pupil cases, there's many different ways to do it, and do the technique which you feel most comfortable doing. But the combination of the high dissection, the phaco chop maneuver, makes these cases really quite amenable to removal without when the pupil actually is really small and the view is limited. If at any point in time you run into an issue or a complication, then you put in iris hooks here, and then you can address whatever issue is going on. You can get better visualization to see and manage any potential complication that may be coming up. So we're working through here, removing the nucleus. And as I said, we are making good progress. I'm already using my second instrument here for this last piece. We have an epinuclear shell here, and that with the Venturi system, that just really comes out very nicely. That may be actually just the last piece of nucleus there, but let's see here how we do. There's still an epinuclear shell there, and we'll see if we get that with the phaco probe or not. And it looks like we are. Okay, and then we still have some cortical material here, and so we'll go with IA to remove that cortical material. But you can see how with the Venturi system, it becomes, you can readily get that epinuclear shell. I think it's harder to do that with a peristaltic pump system. And in fact, since I've moved to a peristaltic pump system to the Alcon Centurion, I no longer hydrodelineate and I no longer leave an epinuclear shell. So it is important when you watch these videos that other surgeons post that you think about what machine they're using and whether you can apply their techniques to your setup that you have in your operating room. And of course, always feel free to reach out. I think for most people who post videos, they enjoy hearing questions and are happy to answer questions about their technique and what machines they use and settings, etc. So here I'm using the Charvel to retract the iris and try and get that cortical material. It looks like this cortical material is pretty sticky. I did not achieve a cortical cleaving hydrodissection here. But we are making progress, and we're able to get that cortical material. This Charvel is a really nice instrument for retracting the iris. Of course, whenever you manipulate the iris a lot, it can increase postoperative inflammation, and you may need to use steroids more frequently than you normally would if there's a lot of iris manipulation. Looks like I'm using a Lester here to pull the iris in. So, one criticism is if we had used a ring here or iris hooks, this part we wouldn't have had to retract the iris so much to piecemeal out this cortical material. The counter argument, of course, is it takes a little bit of time to put in iris hooks, and you have to make 4 extra incisions. But nonetheless, I think both approaches are valid. Now, when I do a cortical cleaving hydrodissection, and I'm able to separate out the cortex from the capsular bag, I rarely have this issue where I have to spend so much time doing IA and retracting the iris. And I think that's part of the reason why I've shifted away from using pupillary expansion devices for most of my cases with small pupil. So what we have left here is some subincisional cortex, which we're able to get here with the IA. My field of view in the microscope, of course, when operating is larger than what we're seeing here in this video, so sometimes we'll go off frame here. Well, it looks like we're doing a pretty good job staying centered. All right, so essentially this cataract is out. We have some material there, it looks like, on the posterior capsule. And so I may end up doing some polishing. It looks like I'm just retracting the iris, taking a look, making sure I'm not having left anything behind. I'll probably want to polish that posterior capsule So I don't, if it was me doing this case today, I'd use a Terry squeegee. I may have been using it back then as well. We'll see here. Looks like I am. So this is a Terry squeegee. It's got a silicone tip. It's a cannula with a silicone tip, and you can use that to touch and irrigate directly on the posterior capsule, which is what I'm doing here. And I will do that to remove any material that's remaining on the posterior capsule. But if there's something that's really adherent, I'm not too aggressive in trying to remove it. I'd rather save that later and do a laser capsulotomy. In any case, at this point in time, we've removed the cataract, we've done irrigation aspiration, removed the cortical material, we've polished the posterior capsule. We're going to inject viscoelastic here to fill the capsular bag. It is possible still to get iris prolapse at this stage of the procedure, so it's important not to overfill here. And then I would expect now that we're going to be putting in the intraocular lens. Okay, so I'm using a corner wand to stabilize the globe through the paracentesis. I'm using a one-handed technique here in terms of injecting the lens. So this is a push injector, and this must be a Softec lens, which is a hydrophilic acrylic lens, which is the lens that I was using during that time period. Placing the IOL here into the capsular bag. I no longer really do this step. I just go straight in with the irrigation aspiration probe. And I'm verifying that the IOL is in fact inside the capsular bag. That capsulotomy looks really small. I would say it's probably in the order of actually 4 millimeters or, 4 millimeters or less. Probably 4 millimeters here. So then we go in with IA, and we are going to be removing the viscoelastic and any remaining cortical material that wants to come forward. So it looks like here I'm starting behind the IOL and removing viscoelastic from behind the IOL. And then we'll remove viscoelastic from the anterior chamber. I'm going to speed this up here. So this is now 2x speed. And once again, it looks like I'm going in with the Charvel, and I'm looking for any remaining cortical material. So I showed this case because, number one, it is from 2016. And I realized I've been doing this technique where I don't use pupillar expansion devices now for quite some time. And then also, I think as you gain experience over the years, you don't spend as much time double checking things like we see that I'm doing here. So I have double checked, made sure there's no cortical material remaining. I irrigate the wound and I irrigate the paracentesis. And we'll check the wounds and make sure they're watertight. So I know we're all surgeons and we have different preferences for our techniques. And the goal here is that we learn from each other. If you're in training, it's important to see different techniques and really see what you like and work towards the techniques that you like. Over the next few weeks, I'm going to be posting small pupil cataract surgery cases. And I look forward to hearing your feedback. And if you have requests for certain videos you'd like to see, please comment in the comment section below. Thank you for your attention. Have a great day.